Excuse me. We're going on the record at 5:05 p.m. Pardon me. This is Volume 1, Media Unit 1 of the video deposition of Kyle Boone, Ph.D., taken by the plaintiff in the matter of Robert Rios versus Ames True Temper, Incorporated, filed in the United States District Court, Central District of California, Western Division, case number EDCV11-320 CAS. This deposition is being held at, where are we?
24586.
24586 Hawthorne Boulevard in Torrance, California. My name is Michael Cooley from the firm Ronan Video Services, located at 46-E Peninsula Center, Suite 516, Rolling Hills Estates, California, 90274, and I am the videographer. The court reporter is
Laura Guerrero.
Laura Guerrero from the firm Hines, with offices in Los Angeles, California. Counsel and all present will now state their appearances and affiliations for the record.
I'm Dan Powell. I represent Mr. Rios.
Jennifer Villabro on behalf of Defendant McMaster Car Supply Company.
Will the court reporter please swear in the witness?
Please raise your right hand. You do solemnly swear that the testimony you will give in the taking of these proceedings will be the truth, the whole truth, and nothing but the truth, so help you God.
Yes, I do.
Good afternoon, Dr. Boone. We had sort of a adventure here trying to get this thing underway, but we are finally underway, a little bit late, so I'm going to try and expedite this as best I can, realizing some of the time constraints that you have. Have you given a deposition before?
Yes, I have.
How many times approximately would you estimate?
Over 100.
I'm going to mark this first document as Plaintiff's A. It's a Rule 26 disclosure of your testimony career. I think you started in '04, if I remember right.
Well, this one picks up in '04, but I had a previous one, but the hard drive collapsed, so I don't have that anymore.
There's 106 cases on there. I counted them. Are any of them a plaintiff's case where you were asked by the injured person to take a look and offer your opinion?
Well, I'm not sure I remember. So a lot of these are criminal cases.
That wouldn't be a plaintiff asking you to give your opinion. We'll get into the scope of your work, but I'm wondering if of the 106 that you did supply the court, are any of them an injured person that asked you to, through their counsel, that asked you to evaluate them for some sort of cognitive or emotional dysfunction?
Well, I know that Boole is.
Boole, spell that one?
Boullie. But then a lot of these names I don't even recognize.
Well, in a general sense, ma'am, since you've given a deposition well over 100 times, can you give me a reasonable approximation how many of those are plaintiff's cases on that list of 106?
Well, a lot of these are criminal cases, so it wouldn't be 106.
Ma'am, I'm just asking, are any of those 106 a plaintiff's case other than Boole?
I don't know. From the cases in 2006, 2007, 2004, I don't remember the cases. I don't recognize the names.
In this time frame that you've designated here to the court, how much of your work is on behalf of plaintiffs?
At the current time?
At the current time and go back to '04?
Well, it changes over time. Currently, I'd say about 90% of the time I'm retained by defense.
And 10% of the time you're retained by a plaintiff's firm?
Right.
In a personal injury matter?
Yes.
Can you name any California attorney that's hired you in the last year?
Well, this person who did the Boole case did. I don't recall her name at the moment.
Any other besides Boole?
I know. I don't remember at the moment.
You don't recall the name of the counsel in the Boole case?
No, it was a woman, but I don't remember her name.
You recall what your bottom line opinion was in the Boole matter?
Yes, that he had an anxiety disorder precipitated by harassment at work.
Have you ever been retained by a plaintiff's attorney where there was an issue of a traumatic brain injury?
Yes.
How many times?
I don't recall at this point.
Is it more than a handful, or is it 100? Can you give me an idea?
I'd say probably about 20.
Now that we've talked about it, any of them on the list?
Well, again, I don't recognize a lot of these names. There is a case, Herb Branson. I remember I was retained as the plaintiff expert. Then quite a few others, but I just don't recall those names. There was one, Haney, Haney.
TBI case?
Yes.
Any others come to mind?
No.
Since you've given a deposition many times in the past, any need for me to go over the admonition with you?
No.
You understand the rules of the game?
Yes.
You're under oath?
Yes.
I understand you're supposed to tell the truth here today.
That's correct.
Are you able to give me your complete, final, full opinions this afternoon?
I believe so.
Anything else you think you need to do?
No.
Let's talk about your educational background for a moment. I have a CV somewhere around here. The one that I was supplied, Doctor, it's got a date of revised March 2006. Do you have a more current?
Yes, I do.
And this one that you handed me, it's revised to April of 2012. We'll mark this too, and we'll attach it. Why don't you put that case list aside so we don't get it mixed up? I'll put a 2 on this. In 1978, you got a degree in speech pathology at Loma Linda, correct?
Correct.
You wanted originally to be a speech pathologist, I take it?
I thought about it.
But you did get your BS in that.
Yes.
And then you got a master's of clinical psychology, a place called the California School of Professional Psychology. That would have been 1980.
Correct.
Is that, I'm a little bit confused. Is that Alliant International?
Yes, it is.
Is there some reason that you don't put Alliant International as the actual professional school where you worked?
Well, when I graduated, it was California School of Professional Psychology, and then the name was subsequently changed.
When was it changed?
I don't recall, actually.
And then you went on, same place, California School of Professional Psychology, and PhD in 1984.
Correct.
Correct. When did you make the choice to switch from speech pathology to clinical psychology?
Well, I was actually a double major in speech pathology and psychology. So I feel like as a neuropsychologist, I have found the melding of those two majors.
When you applied for your master's, did you apply to any university-based institution?
I believe I did.
Did you get accepted to any university-based?
No, I didn't.
In your CV, it contains your employment activities, and then it also has your bibliography.
Correct.
And currently, what are you doing professionally?
I'm a full professor at Alliant University in the particular school that's called the California School of Forensic Studies. I'm a full professor in that program. Then I also have a small private practice on the side where I do neuropsychological assessments.
And you make approximately $250,000 a year in your side practice?
I don't know. I don't think that much.
But doctor, do you recall signing a declaration under penalty of perjury that you made $250,000 a year in that practice?
Yes, I do.
Do you now recall that you make approximately $250,000 a year in your side practice?
That was the estimate I provided, but I really had no data to go on, so I had to provide it. That's what I turned over.
Well, doctor, you signed a declaration under penalty of perjury and advised the court because it was a disputed issue, I'll say, in your deposition when you refused to answer that question. And you signed a declaration that you made $250,000 per year. Was that true?
According to my best estimate at the time, but I had no data to rely upon.
What's your feeling today? Do you make more than that or less than that?
I believe less than that.
What do you think you really make?
I don't know. I get a lot of 1099s from different sources, from book sales, from test sales, from doing workshops, medical legal work, criminal cases, at the request of disability insurance companies. And when the 1099s come in, I do not divvy them up into different categories. So I don't really know.
When you signed the declaration under penalty of perjury, did you appreciate that you were advising the court that this was true and accurate information, that you made $250,000 per year in your side practice?
That was the best estimate I had at that time. But again, I had no data to rely upon. I don't know if it's accurate or not.
Did you tell that to counsel, that you had no data to come to that number that
Yes,
you
I
were
did.
supplying?
And I was told I had to provide a number, so I provided a number.
Is that case on the list?
Which case?
The one where you supplied a declaration that you made $250,000 per year in your side practice?
I don't know which case that's, I don't know which case it is.
I'll mark this document 3. Is this the declaration or copy of the declaration that you signed under penalty of perjury that you made $250,000 per year in your side practice?
Yes.
That's your signature on
Yes, it is.
the second page? Thank you. And now you tell us that you are now a professor at Alliant International University.
That's correct.
What makes it international?
They have campuses outside of this country.
They have one campus in Mexico. Do they have any other campuses that you are aware of?
They have, they do satellite programs in Rome, in South Africa, in, I believe, Hong Kong.
I'm going to show you some data that I took off the net from Alliant International University. They do have a psychology school there, do they not?
It's California School of Professional Psychology.
And you don't teach in that school, do you?
No.
In the school you teach in, it's called Forensic Studies.
Correct.
What's the definition of forensic studies?
Well, it has to do with the judicial system. So teaching psychologists how to interact with the judicial system.
It's lawyer-based.
Well, not necessarily. I mean, we train students who end up working in prisons, providing therapy for prisoners, who work in police departments, providing services to police officers. So it's anything having to do with the judicial system.
What is your definition of malingering?
Deliberate faking of symptoms for an external goal.
It's a conscious effort to deceive.
That's correct.
And that is a research interest of yours, isn't it?
That's correct.
And your research interest is detecting, I'll just say the word liars, who are trying to seek a monetary gain in a litigation context?
No, I'm trying to detect people who are deliberately faking symptoms for an external goal. That's the definition of malingering.
And that's one of your specialty areas also, isn't it?
Well, I'm not sure what you mean by that. It's an
Well-
area that I do research in.
Well, in terms of what you offer to people that hire you, one of your areas of expertise is the detection of malingering. Would that be a fair statement?
I don't think it is, because it's a part of every neuropsychological exam. So you don't just do an exam and the goal is detection of malingering. It's a part of a complete neuropsychological exam. So my specialty as neuropsychological testing.
Have you written a book on malingering?
It was on feigned cognitive impairment and how to assess for it.
What's the difference between feigned cognitive impairment and malingering? Is that just a nicer way to say it?
No, people can feign symptoms non-consciously for psychological reasons. So the purpose of the book was to show how non-credible symptoms could be detected, whether or not that is malingering.
In some of the reports that you generate for defense counsel, do you point out, if it's your opinion that there's a malingerer here, that you'll say so?
I usually don't use that term, but if there's compelling evidence for that, then I will.
Within the last month, have you used the term malingerer in a report that you prepared?
I don't recall, actually.
Within the last 2 months?
I don't recall.
How many reports do you do in a month or a week? Any time frame convenient to you?
I probably do maybe 3 or 4 a month.
In this case, the Rios matter, you were retained by defense counsel to assess Mr. Rios, correct?
That's correct.
And then you sent a bill for your professional services. I'll mark this next one. Where are we on? 4. That's a bill for $10,250. And then I have a question for you. There's a bill attached to it for $6,000. It looks like it's somebody that scored the test.
This was shown to me earlier today. I have no idea what that is.
Neither do I.
I have no idea. I worked for Jeff Schaefer many years ago. Haven't worked with him in over 8 years. I have no idea what this is.
Well, that clears it up, because I had no idea. You did score the test yourself.
Yes.
Since we referred to it, I'll just mark it 4A, your bill, and then this Schaefer bill, we'll mark it 4B. And as far as you're concerned, it's just an inadvertent attachment.
It has nothing to do with my work in the case.
Have you billed anything since the $10,250?
I did on May 21st. I printed this.
Can I
Yes, you
attach
can
it?
have that. Yes.
We'll call it 5. This is your updated bill?
Yes.
So you charge an additional $2,000?
Correct.
You're charging me for your time today?
I am.
What's the charge?
$500 an hour.
Trial testimony?
$2,500 for a half day.
I want to talk now for a moment about what you are allowed
This
to
might be
do
yours.
as a psychologist, neuropsychologist. Is there a license for neuropsychology?
No.
You get a license as a psychologist or a clinical psychologist issued by the state of California, correct?
That's correct.
And then within the field of psychology, there may be other specialty areas that apply.
Correct.
Within your field of psychology, does law allow you to make medical diagnoses?
Well, certainly we can make psychiatric diagnoses according to the DSM-IV.
In the state of California, if you know, are you allowed to make a medical diagnosis?
Well, do you include psychiatric diagnoses under medical?
What we're going to discuss right now is a couple of items. This is, I'm going to mark this 6. No, I'll mark this one 6. And what it is, counsel, this is out of the Business and Professions Code. It starts at section 2900, and this deals with the psychologist and the psychology license. And then it explains what California says a psychologist can do. I've highlighted it. Take a look. First question I have for you before you take a look at Dr. Boone, have you ever seen what the state says you can do
Yes.
under your license?
Yes.
Is it your belief that you can opine concerning medical diagnoses? I'm not talking psychological or cognitive. I'm talking medical diagnosis as defined by the Business and Professions Code.
Well, you seem to be insinuating that a psychologist cannot make a medical diagnosis. That may be true according to the business code, but certainly psychologists are trained, neuropsychologists are trained to comment on how medical conditions influence cognitive ability. And certainly I can read medical records and determine if a medical condition is present and include that in my report.
Doctor, real simple. Is it your belief that you can make a medical diagnosis in assessing a patient?
I'm not sure of your question. I can certainly, as a neuropsychologist, if a patient has a medical condition, it is my responsibility to comment on how that influences that person's thinking skills. That is my area of expertise. So I'm not making the diagnosis, but absolutely, I'm the one who determines how that condition influences thinking skills.
Well, doctor, your explanation is you're adopting a diagnosis made by others. The question I have for you, are you of the belief that you can come to a de novo medical diagnosis of a medical condition in a patient you are assessing? That's a yes, no, or I don't know.
Certainly, if there's evidence in records, evidence of high blood pressure readings, I could certainly put that in my report.
Doctor, I don't want to quibble with you about it. That is adopting somebody else's reference in a medical record. A medical doctor may say in a chart somewhere, patient has X. Dr. Boone says the medical history is patient has X. Does this have an implication for the psychological or cognitive issues I was asked to address? I get that. I'm asking you, do you believe that you can make a medical diagnosis?
Well, again, I have to be very careful in how I answer this, but certainly in the DSM-IV, there are diagnoses. So this is in the Psychiatry Diagnostic Manual, and psychologists absolutely can make diagnoses according to that manual, and some of them are things like mental retardation, which is physically based, dementia, which is physically based. So yes, we can make those diagnoses.
If I can have this, I want to refer you specifically to the language of the Business and Profession Code, which is your license. The application of these principles and methods includes, but is not restricted to, diagnosis, prevention, treatment, and amelioration of psychological problems and emotional and mental disorders of individuals and groups. You understand that you can do that?
Yes.
I'm going to show you another part of the BMP code, and I'm going to mark it 7. This pertains to physicians, medical doctors, and what the scope of their practice is. And if people that are not holders of medical licenses diagnose things, what happens to them? Have you seen this one before? Just for the record, counsel, while you're looking at that, the scope of practice for the psychologist is set forth in BMP Code section 2903. And doctor, were you aware that if you do not hold a medical license, that coming to a medical diagnosis is a misdemeanor in this state?
Well, as a neuropsychologist, we are trained to make diagnoses like dementia. Every neuropsychologist I know, including Dr. Lechuga, would make a diagnosis of dementia, make a diagnosis of mental retardation. So any diagnosis contained in the DSM-IV, we can use as mental health professionals.
Doctor, were you aware, as you're looking at this code section, that if you arrive at a medical diagnosis in a patient you are evaluating and or treating, it is a misdemeanor in the state of California? You are not allowed to do that.
Well, I would quibble with that. As a neuropsychologist, I can make a diagnosis of dementia, which is a medical condition.
Is a traumatic brain injury a medical condition?
Yes, it would be.
Do you believe you have the authority under the license granted to you by the state to make a diagnosis of traumatic brain injury or doesn't have traumatic brain injury?
I actually agree that psychologists should not make that diagnosis.
Is gliosis and the etiology of gliosis a medical diagnosis?
I don't know that that's true.
Gliosis is scarring in the brain?
Yes.
Is gliosis a medical condition?
Yes, it would be.
Do you feel that your license allows you to make a diagnosis of the cause or causes of gliosis in a patient that you are evaluating?
Well, let me back up. What I said was that those findings would be most consistent with the findings that we see in long-standing blood pressure. I've done research in that area. I know that literature. So you will not see in my report where I say diagnosis and then list it. But I know as a professional who's done research in this area that the most likely cause of periventricular white matter abnormalities on brain imaging would be vascular factors. And it has nothing to do with this business code. It has to do with the scientific literature that I've contributed to. It doesn't say in my report diagnosis equal.
Doctor, in your report, you come to a conclusion as to the cause or probable cause, in your opinion,
Yes.
as a psychologist, of a medical condition known as gliosis in the human brain, correct?
Yes.
Would you agree that that is a medical diagnosis?
It's a medical condition, but I can comment on what the most likely cause of that is, absolutely based on my experience.
Doctor, I understand that you can. I'm asking you, do you understand that that's a violation of the business code? It's
I
a violation
disagree.
of your license.
I disagree. I'm not providing medical diagnoses. I'm saying based on the literature that I've contributed to, the most likely cause of white matter abnormalities on brain imaging would be the long-term effects of things like high blood pressure and diabetes. That's a known fact in the literature, and I'm absolutely able to put that in my report.
But is it your opinion, doctor, today, that that is not a diagnosis of a medical condition in a human being?
I would say no, I was not providing a diagnosis. I was citing what the research literature says would be the cause, the most likely cause, of those imaging findings.
In those 100 and so reports that you have generated in your career, have you ever come to the conclusion that a patient had or did not have a traumatic brain injury based upon your review of the records and your evaluation of the patient? In other words, an opinion on the condition.
Yes, absolutely.
Is that a violation of the Business and Professions Code?
No, it is not.
Put that in the stack so we won't get it lost. Let's focus on Mr. Rios for a moment. When were you first retained?
It looks like probably in about January, no, sorry.
Just approximately.
Probably in January or February of this year.
And you were supplied data about Mr. Rios?
Yes.
I had an opportunity in our long break before we started to go through, and it looks like some of the material is a compendium. Did you perform that, or is that something that was supplied to you?
What do you mean, a compendium?
Well, if you look at some, like this big stack of documents here, about a quarter of the way down, it's a mix of medical records.
I went through the records and gleaned out material that wasn't relevant. So some of them will just indicate that something was sent to me, but if I reviewed it and if it had no relevance to me, if it was laboratory findings, then I shredded it.
This big one here.
This one?
No, go down a little bit. Yeah.
This one?
Is that your test data?
No, this is Dr. Lechuga's
That's
test data.
Lechuga's? Oh, by the way, did you send Lechuga yours?
Yes, absolutely. I think
did.
twice.
Did you send him the tape recording?
Yes. On March 26, 2012.
Both items?
Yes.
What I was getting at, when I was going through the records, it looked like some of the records that were bound together looked like they were pulled from various sources. It wasn't like one healthcare provider. It looked like there were multiple providers and various things sort of stuck together. I'm just asking if that was supplied to you or if that is of your making.
I didn't put things together, so if it looks like they were put together from different sources, that's what was in those records. So sometimes a provider will get records from other people. So that's the only way there would be an amalgamation of different data sources within the same clip.
And the blue stickies, that's you?
That's me.
Prior to evaluating Mr. Rios, did you get a chance to review these records?
Yes.
Your report, we're going to mark that 7. There's 2 reports. You have the original report and the date on that. Where is it?
It's March 15, 2012.
I'm looking at one that's got a February 29 on it.
Oh, sorry, that was the date of the evaluation. The date of the report is March 15.
March 15. Then you have another shorter one.
Right.
So let's just talk about this big one first. We'll call that 7. I'm on 8, thank you. We'll call it 8. And we'll just call this your initial report concerning your evaluation. And then you have a certain template that you use.
Generally.
And you have a neuropsych evaluation, records reviewed, and then you list all the records you reviewed, correct?
Correct.
Did you ever see the deposition of Dr. Horshak? Dr. Horshak was the treating neurosurgeon, and he gave the deposition in this case.
If it's here, then
It's not there, and it's
then
not
I-
on the list.
then I didn't receive it.
Did you receive any information that Dr. Horshak, in his deposition, said that Mr. Rios, by his personal observation, had a bruised brain on imaging in the frontal lobe and was diagnosed with a traumatic brain injury? I mean, it's the diagnosis in the chart. Did you receive that information?
Well, I didn't receive his deposition.
Did you receive the, I know that, but did you receive information, since you haven't been supplied his deposition, that that's in sum and substance what he said? The guy had a brain bruise, he had a subdural hematoma, skull fractures, and he was diagnosed with those magic words, traumatic brain injury, in the chart.
I have no recollection of that right now.
Is this the first time you've heard about Dr. Horshak?
I think it might have been mentioned to me today, before
What
we
was
came
told
over.
today?
Just, I think that a deposition of his did exist.
Another thing that's not on here is the report of Dr. Larson. Dr. Larson is a psychologist, and I did see that the Larson report is in your stack of stuff,
That's
although it's
correct.
not referred to in either one of your reports.
That's correct.
When did you get the Larson report?
Today.
Do you understand how Dr. Larson fits into this matter?
Not really. I think it's workers' comp related. That would be my understanding.
I'll represent to you that Dr. Larson was an agreed medical examiner. Do you know what that means in the workers' comp context?
Yes.
What's your understanding? It's changed over time, but currently, do you know what an agreed medical examiner is?
That the attorneys on both sides have to agree to this examiner.
Did you disagree with Dr. Larson's assessment of this man?
Yes, I did.
Dr. Larson, who conducted neuropsychological testing and interviewed the client, says diagnostic impression, cognitive disorder, and this is the Axis 1 diagnoses. Do you agree with any of those?
So we're on which page here?
This would be page 27.
I think he does have a chronic mood disorder, long-standing. I don't think he has PTSD, or at least we have no objective information for that. Bipolar disorder is in the records, and alcohol abuse is in Dr. Zackler's and Dr. Lechuga's records. He may have a cognitive disorder, NOS, but I would disagree as to the cause.
On page 28, Dr. Larson, the agreed medical examiner in the workers' compensation system, diagnostically, it's the top of the page, diagnostically cognitive disorder NOS and mood disorder NOS seem to be the most reasonable diagnosis at this time. You agree or disagree?
I think the cognitive disorder for me would be a rule out. I don't think it's definitive. He certainly has a long-standing mood disorder. I would agree with that. Although at the time I saw him, he was not depressed.
Next paragraph, objective findings from this examination, mental status examination, indicate Mr. Rios has generally intact functioning with some mild to moderate problems in pain, memory, attention, anxiety, and pessimism. Other objective findings from other reports appear to indicate mild traumatic brain injury as well as his facial and eye injuries. Do you agree with any of that?
Yes, generally intact functioning. Whether or not he's experiencing pain is debatable given the results of the MMPI. He does not have evidence for memory problems on my exam. He did not have evidence, he did have some low scores on attention, but the problem is that those findings are found in individuals who speak English as a second language, and that was not considered by Dr. Larson. And it actually is an ethical mandate that you have to consider cultural and language factors when you interpret psychological test results. In terms of anxiety, there was actually no evidence for anxiety on personality testing. Pessimism, certainly at the time I saw him, and also on Dr. Larson's exam.
Are you misspeaking when you say Larson? You mean Lechuga? I'm talking about Larson's exam.
Right.
I'll represent you. Dr. Larson pretty much agrees with Dr. Lechuga, so maybe you're getting the two confused.
Well, no, they had disagreements, actually. Dr. Larson said that he appeared to have substantially improved from Dr. Lechuga's exam.
No, ma'am, you misunderstood me. In terms of mild to moderate problems with pain, memory, attention, anxiety, and pessimism, they are pretty much in agreement. You are the only person that disagrees. Did I state that accurately?
No, I don't believe that you did.
Where did I go wrong?
Well, if I can find it here, I read it very quickly before this deposition, but it was my understanding that Dr. Larson said that their depression was essentially in remission.
Ma'am, I'm focusing on pain, memory, attention, anxiety, and pessimism, not depression.
Well,
These two gentlemen have pretty much the same opinion. You disagree with both of them, correct? In that regard?
so it says here he has recovered substantially but incompletely from his injury in 2010, both physically and psychologically. So he's indicating there has been a change since Dr. Lechuga saw him.
Matt, is it not true on page 28 that Dr. Larson's bottom line conclusion was on objective testing that Mr. Rios has mild to moderate problems in pain, memory, attention, anxiety, and pessimism?
That's what he wrote.
Yeah.
That is true.
And you disagree with that, I take it?
And as I just said, there are issues about pain report. Dr. Larson didn't give him the MMPI, so it was a substandard exam. When you do a forensic exam, you have to give personality tests that actually have validity scales so you can check to see if your person is providing accurate data. Dr. Larson didn't give the MMPI or any other personality inventory that has validity scales in it, so we cannot accept his, quote, objective findings on personality testing because the Beck and the Hamilton are inappropriate in this context.
So Dr. Larson got it wrong?
He got the test wrong, absolutely. So we cannot comment about the pain report from his exam because he gave the wrong test. On my exam, it was clear that Mr. Rios was not reporting physical findings in a completely credible manner. In terms of memory, as I said, there was no evidence of memory problems on exam. In terms of attention, he did get a low attention score, but you have to consider the impact of English as a second language on those test scores, which was not done in this exam. In terms of anxiety, there was nothing on the MMPI that indicated anxiety. And then pessimism, you're not willing to call that depression. Certainly on my testing, there was no evidence of depression. There is no test for pessimism that I'm aware of. So none of these have really objective findings. There's no underpinning.
He got it wrong.
Yes, he did.
Subjective findings would encompass Mr. Rios's complaints noted above. They appear to be consistent with the medical evidence available, and there is no evidence of malingering. Do you agree with that?
No, not based on his data, I do not. He didn't give. He gave one symptom validity test, which is completely inadequate. It's completely insensitive. He gave one, which is below practice guidelines, which I sat on the committee and co-wrote, so I know what those practice guidelines show. He is below practice guidelines in terms of detection of malingering. And then he didn't give the personality inventories that would have said whether or not he was accurately reporting psychological, physical, and cognitive symptoms. So this is a substandard exam that did not rule out malingering.
Is there evidence of malingering in this test, Dr. Larson's test?
Well, if you don't check for it, how can you find it?
The question is, there is no evidence because you say he didn't check for it, correct?
That's correct.
In page 30 of Dr. Larson's report, the agreed medical examiner in the workers' compensation case, summary and integration, Mr. Rios has recovered substantially but incompletely from his injuries on 1/18/2010, both physically and psychologically. He has residual visual, sensory, pain, memory, attention, and emotional problems discussed below, subject, of course, to the scope of practice limitations. Do you agree with any of that?
I do not. Well, obviously he has visual problems. That is true.
On page 31, Dr. Larson states, using the pre-2005 guidelines, Mr. Rios appears to have the following limitations based on his evaluation. Minimally to mild impaired in the ability to understand, remember, and complete simple commands. Do you agree or disagree?
I disagree.
Number 2, mildly to moderately impaired in the ability to do, understand, remember, and complete complex commands. You agree or disagree with Dr. Larson?
Disagree.
Number 3, minimally to mildly impaired in the ability to interact appropriately with supervisors, coworkers, or the public. Agree or disagree?
That may be true.
4, minimally impaired in the ability to comply with job rules such as safety and attendance. Agree or disagree?
Well, not from a cognitive standpoint, but from a personality standpoint, there are results indicating that he has issues with authority figures and may not follow recommendations. So if we're talking from a psychological standpoint, perhaps he does not comply with job rules.
Number 5, mildly impaired in the ability to respond to change in the normal workplace setting. Agree or disagree?
I would disagree.
Mildly to moderately impaired in the ability to maintain persistence and pace in a normal workplace setting. Do you agree or disagree?
I disagree.
9. We'll attach Dr. Larson's report as 9. And again, Doctor, I'm giving you the short version. So. In going through your test, summary and conclusions, page 10. And again, I've seen many of your reports, and it looks like your template. I've seen this language in this format many times. In your summary and conclusions, you generally start with cognitive function, then you go to psychological functions, correct?
That's correct.
On cognitive function, the patient passed measures of symptom validity from 8 of 9 separate tests. Thus, evidence suggests that he was most likely performing to his true capability, and that obtained test scores are an accurate reflection of his true neurocognitive ability. In other words, he's not lying, he's not a malingerer, correct?
That would not be the correct wording. What it means on performance-based tests, when you check to see if the person is performing to their true ability, the evidence suggested he likely was.
He was given his best effort.
It would appear so, yes.
And the evidence that you got in your test evaluation is a true reflection of his neurocognitive ability, correct?
Correct.
But then you have another part of your exam on the psychological function. You believe he was making stuff up?
Well, what the objective test results indicate is that the way he reported his symptoms was not plausible. So we have performance-based tests where you actually check to see how their memory is, how their attention is. And on the performance-based test, he appeared to be performing to true ability. But on the MMPI, when we asked him to report his symptoms, the indicators came up on my exam, Lechuga's exam for psychiatric symptoms, and Dr. Zackler's exam, that Mr. Rios did not appear to be reporting symptoms plausibly.
How does somebody how can you be that smart? How can you fool Dr. Boone on the cognitive part of the test, and yet you can't fool her on the psychological part?
What I said was, when he's asked to actually do a task, he appears to be performing to his best effort. But when you ask him to describe his symptoms, he does so in a non-plausible manner.
Do you think he's consciously trying to fabricate?
I don't know if this is conscious or not, but the symptom report is not plausible. On my exam, Dr. Zackler's exam, and Dr. Lechuga's exam.
Let's talk about some of the things, see if we can agree on some things. Was Mr. Rios struck in the face by a high-speed projectile?
Yes.
Have you seen these photographs?
I believe I did.
Hold it up to the camera, please. I know you're not a medical doctor, but what's your take about that? Was he injured in this accident?
Yes.
Did she just violate the Business and Professions Code with that?
I'll put it this way. Does he have a medical history that suggests that he was injured when he was struck in the face with a high-speed projectile?
Yes, he sustained injury.
Does the evidence suggest in the record that the blow resulted in multiple skull fractures, and that's plural?
Facial fractures, yes.
Was a skull fracture? You understand the difference between skull and face?
Well, it's bony structures on the front of the skull, yes.
Did he have multiple skull fractures, ma'am?
He had multiple fractures on the head, yes.
Did he have a fracture of the C7 vertebral body?
I believe so.
Do you understand the mechanism, how you can get your neck broken when you're hit in the face with a high-speed projectile?
I have no personal knowledge of that, no expertise in that.
You ever heard of coup contre coup?
Yes, I have.
Do you believe he suffered a coup contre coup?
In terms of a brain injury?
In terms of any type of injury in his body as reported by history?
That would be out of my area of expertise if we're talking about his neck.
When Mr. Rios was struck in the head with the high-speed projectile, did he suffer bleeding below the dura?
I believe that there was some blood detected.
That's also known as a subdural hematoma.
Correct.
Was that in the falx? That's F-A-L-X.
Yes.
Where is the falx?
It's the area between the two hemispheres. There's a piece of connective tissue that comes down between the two hemispheres.
That's in the frontal lobes, correct?
Well, actually, the falx goes all the way between the two hemispheres, but it's my understanding that the blood was in the frontal area.
In the frontal lobes of the human brain, what does it control?
Things like planning, organization, thinking through consequences, generating ideas, motor function.
Executive functions.
That's correct.
I mean, it's kind of like what makes people people, right?
Well, all of our thinking skills makes people people. Language makes people people.
But in terms of personality, mood, expressing yourself, things like that, is that in the frontal lobes?
To some extent.
Based upon your understanding, was enough force applied to the blood vessels under the dura to cause a shearing injury and cause those vessels to bleed?
That would be out of my area of expertise.
Is it out of your area of expertise to know that there was sufficient force applied to blood vessels on his brain to the point where the vessels failed and bled?
That would be out of my area of expertise.
Is it true that data show that MRI, CTs many times cannot pick up a mild traumatic brain injury? You just don't see it.
That's true.
Is your understanding it's there, but the resolution in our technology just can't see it yet?
It may be there, it may not be there.
I'm talking about situations where it is in fact there.
Counsel, you have pens ready.
There are data show that there are in fact, it's proven, you can have a mild traumatic brain injury and it will not show on MR or CT imaging because the resolution cannot pick up the injury.
That would be out of my area of expertise.
You've read that somewhere?
Well, it's actually very controversial, whether or not, what the underlying pathology would be in mild traumatic brain injury and whether it in fact exists.
Well, that's an interesting point. Do you believe the mild traumatic brain injury in fact exists?
Yes, I do.
In the book that you have in front of you, is there not a section that says in many instances the condition has occurred, the patient has suffered a mild traumatic brain injury, but it's not evident on neuroimaging?
That's well known that it's not evident on neuroimaging.
And do you know why that is?
Well, a mild traumatic brain injury is the same thing as a concussion. What the debate is that concussion is an alteration in mental status due to a blow to the head. And the question is there any underlying permanent changes in tissue, or is it a transient experience because of the acute injury that in fact normalizes? I think it's an open question whether or not there's any permanent pathology of the brain in a mild traumatic brain injury.
Does data show in this case that Mr. Rios in fact suffered a traumatic brain injury when he was struck in the head with the high-speed projectile?
What I said was that the findings from his injury would be consistent with at most a mild traumatic brain injury.
Is it true, doctor, that data show that in some patients that suffer a traumatic brain injury, they may experience symptoms, psychological and cognitive, for a long time?
Yes, they may.
And is it true that some people with a mild traumatic brain injury never fully recover? There's a patient population where that is true.
Well, getting back to the last question, yes, there's a subgroup who reports symptoms, but it's not a direct effect of a brain injury. The research really shows that the only predictors of long-term symptoms from a mild traumatic brain injury are litigation status and a pre-existing psychiatric history. So yes, there are people who report symptoms on a long-term basis, but it's not a direct result of the brain injury.
Does Mr. Rios have a pre-existing psychiatric history?
Yes, he does.
So he's in that subset.
Yes, he is.
And to go back to the question that I had for you, it's true, is it not, the data show that there are people with mild traumatic brain injury who never fully recover?
Well, I would argue they do recover, but they continue to report symptoms. And there's a lot of literature about how people misperceive their own functioning, and they view themselves as dysfunctional when they are not. So what we find, and there's been research on this, people will report symptoms, say they have memory problems, attention problems, you test them, no memory or attention problems. So they report symptoms, but in fact they do not have them. It would be incorrect to say people do not recover from a mild traumatic brain injury. They may continue to perceive that they're dysfunctional, but they are not.
The testing that you did on Mr. Rios, he had abnormalities, did he not?
Possibly.
He was not normal in the cognitive testing that you did that you found to be credible. True?
Possibly.
In page 11 of your report, you state, it is not likely that the injury on January 18, 2010 is the cause of the patient's weakness in verbal language processing and visual perception spatial skills. You attribute that to some other etiology, don't you?
Correct.
Is it consistent with the symptoms that he reports? Is it consistent with a traumatic brain injury?
Is it consistent with 2 years after a mild traumatic brain injury? No, it is not consistent.
Is it consistent with that symptom complex for some period of time? That you have patients that have just this kind of reporting for some period of time who have in fact suffered a traumatic brain injury?
I would say the findings are not consistent, are not what you would expect for the residuals of a mild traumatic brain injury, say within the first few days or weeks after the injury. The pattern of scores is not what you see for the acute effects of a mild traumatic brain injury.
Is it consistent for some period of time? The exact thing that he was showing on these tests?
As I just said, no. These are not what we expect to see acutely after a mild traumatic brain injury. You do not see losses in processing speed only in the visual area. You would see problems in processing speed across all time tests. He's only down on verbal processing. You also don't see declines in visual perception. That's not a deficit that's commonly reported after a mild traumatic brain injury. What you expect to see after a mild traumatic brain injury acutely would be problems in processing speed, attention, perhaps memory, perhaps executive skills. That's not the pattern he's showing on my testing.
Just some of them, as you've outlined here. And you feel that that's inconsistent with residual from a traumatic brain injury.
Right.
And you attribute that to what?
Well, first of all, on my testing, he only had 2 impaired scores and 2 low average scores. Everything else was average or higher. And a very, very important learning experience I had at Harbor UCLA when I ran the neuropsych testing service there for 22 years. And we actually tested normal controls as a part of research. And before I tested them, I thought normal people were normal. They are not. So we found that in our normal controls who sign up for research, these are people with above average IQ, 14 years of education, 3/4 of them obtained 1 impaired score, and 20% of them obtained at least 2. So in Mr. Rios's case, we have 2 impaired scores, 2 low average scores. Everything else is average or higher. it is theoretically possible that it represents normal variability. Now, if it does not, then we're left with some, I thought his language skills were a little off. He was down in verbal processing speed, his spelling wasn't great, he didn't know the alphabet well, that was not an overlearned skill. His rapid word generation was low average, and it seemed to me that the most likely explanation for a constellation of arguably mildly lower language skills would be a pre-existing language disability. You don't see language skills knocked out specifically following a mild traumatic brain injury. And he in fact reported that he didn't do well in school. His spelling skills are 10th grade level. He made mistakes in reading simple words. That was not due to vision because these were big words. And he made mistakes in saying the alphabet. So that seemed to me, he attributed his poor performance in school to lack of interest. But in my experience, when people have trouble in school, they are also not interested in it either. So I think the question of a pre-existing learning disability is very possible in this gentleman and would explain both of the impaired scores and at least one of the low average scores.
Doctor, you're just guessing. How do you know what his pre-injury condition was? How do you know what his language skills were before he got a blow to the head?
And I've just explained it to you. He told me that in school he made C's and D's. He attributed it to not being interested in school. But we've got poor grades in school. He's making errors in reading simple words. He's making mistakes saying the letters of the alphabet, and his spelling skills are 10th grade level. So it's not a single data point, it's all of them coming together. The most likely explanation was that he had an undiagnosed learning disability that wasn't picked up in the school that he went to.
Forgive me, doctor, but that appears to be just speculation on your part. Did you get his school records?
I do not have his school records. He's
Did you-
60 years old, I don't have those.
There's a note in there that he wrote to a doctor. It's in the records. It's probably flagged. You flagged it because he misspelled does, I think. But the rest of that looks pretty sophisticated. Did you factor that in? This is before he suffered the blow to the head.
So he couldn't spell the word does? I didn't remember that. I mean, that's a simple word. What I said was that he spends a lot of time reading, so I think he's been able to increase his vocabulary. But when you see someone who's down on what we call Stroop A and B, rapid word reading, rapid color naming, the first differential would be a learning disability because those are the two tests in our battery that are most sensitive to a learning disability. So that'd be the number one rule out, not a mild traumatic brain injury 2 years earlier. It would be a pre-existing learning disability.
Is there any suggestion in the record to support your speculation that he had a learning disability before he suffered a blow to the head?
I just went through that. He told me he got C's and D's in school. Plus, his knowledge of the alphabet is incomplete. He has trouble. He makes mistakes reading simple words.
Now.
And his spelling skills are at the 10th grade level, where you don't get a loss in spelling skills or overlearned academic information from a mild traumatic brain injury. You will not find a single case report anywhere that talks about loss of spelling ability from a mild traumatic brain injury, loss of ability to say the letters of the alphabet, loss of ability to read simple words following a mild traumatic brain injury. You will not find any literature supporting that anywhere.
And what is the mechanism if you have a person that does have a pre-existing psychological problem, and Mr. Rios apparently did have in the record a episode of depression or a history of depression for which he had medication?
Correct. Long-standing history.
When you say long-standing, what does long-standing mean?
Well, in the records it referred to long-standing, and medical records from 2007 refer to long-standing history of depression as well as suicidal ideation, with antidepressants prescribed from 2007 to 2009.
And what happened in 2007?
I believe his business tanked.
And he got depressed.
Correct.
You find that to be an unusual thing?
No, but the records indicate it's long-standing, which would indicate if that notation was made in 2007, it would mean the depression did not start in 2007.
And you're basing your opinion on that, a note of that? Who wrote that note?
I'll find it for you.
Do you have any idea who wrote the note?
It was a treater. I believe it was in Shaba Galeb, Michael, those records.
Does the record show that the first time he took a medication for depression was in '07?
Well, it's my understanding that's when these records start. So I don't have any records prior to 2007.
Do you have any evidence that he received any type of medical intervention for depression before '07?
No, because I have no records before 2007.
And why is it on a psychological, cognitive evaluation that people that have a pre-existing psychiatric condition are more prone for poor outcome from TBI?
Well, it's not poor outcome. Their outcome is fine. They recover. They just don't believe that they have recovered.
Is this a belief that is legitimate, or is it feigned?
They believe that they are dysfunctional when they are not.
But their belief is sincere?
Yes, I think so.
Where are we at? 10. Let's talk about your last report. You know Dr. Zackler?
Yes, I do.
You respect him?
Yes,
He is a board-certified psychiatrist.
I believe so.
You saw his report.
I did.
In your supplemental report, we marked 10, and that's dated May 21. It does say that you looked at, I think you looked at Dr. Lechuga's report, Dr. Fisk, and Dr. Zackler.
Correct.
Did I miss anybody?
I don't think so.
That's it. First, concerning Dr. Zackler, at one point in time you deferred to his opinion on whether a particular patient had post-traumatic stress disorder, correct?
On another case, did I defer to his opinion?
Yep.
I may have.
Do you do it now?
No.
Dr. Zackler, in his report that you have read and considered, his diagnostic impressions, and he also conducted testing, neuropsycho testing, correct?
No, he didn't.
He didn't do any neuropsycho?
No,
Testing.
he didn't do any neuropsychological testing.
He did the Milan clinical multi-axial inventory?
That's correct.
He did the MMPI,
That's
2RF?
correct. That's correct.
That's not neuropsych testing?
No.
And the testing that he did, what would you call that?
Psychological testing.
And after he talked with Mr. Rios, he is a medical doctor, talked to Mr. Rios's wife. By the way, did you talk to Mrs. Rios?
No.
Did you see her deposition?
If it's
not listed.
then no.
So did you get any information from people closest to him how he's changed since he got struck in the head?
No.
You think that's important to know what others have to say about the change in this man pre and post accident?
I think it's very important for the jury to hear that, but the problem with me getting that information is that when I have Mr. Rios take the MMPI to get his symptom report, there are validity scales so that I can get a gauge as to whether or not he is accurately reporting symptoms. I have no such gauge if I interview the wife. And family members do have incentive, perhaps, to present their family members in a particular way to enhance the lawsuit. I have no way of knowing that. I have no way of assessing for that. So I'd rather that the jury hear it directly from the wife. But it doesn't come into my report. I have no way of assessing whether or not it's accurate.
Are you suggesting that Mrs. Rios is lying?
We don't know. We don't know.
Well, you don't know. You didn't see her deposition.
Nobody knows. How would anyone know? There are no validity scales attached to the deposition. How would anyone know?
Doctor, do you believe that you can fool a jury by testifying to an untruth and try to slip one past?
Do I think juries have been fooled?
Yeah.
Absolutely.
All right, doctor. Going back to Dr. Zackler, his diagnostic impression: adjustment disorder with anxiety and depression. Rule out major depressive disorder. This is Axis 1 stuff. History of depressive disorder. 3, cognitive disorder, NOS, multifactorial. Possible effect of persistent post-concussion syndrome. Medications, mood, and anxiety on cognitive functioning. You agree with any of that?
Certainly he has a history of depressive disorder. I would agree with that. At the time I saw Mr. Rios, there was no evidence for any significant anxiety or depression. And then in terms of a cognitive disorder, I would agree it is multifactorial, but the literature would indicate it would not be directly related to any mild traumatic brain injury 2 years earlier. Also, Dr. Zackler did not do any neurocognitive testing. He has no objective information about Mr. Rios' cognitive function. It's based on self-report. And in his own report, it indicates possible impact of over-reporting. So he's even indicating there are issues with Mr. Rios' report, yet his diagnoses are based on self-report.
So you disagree that there is a post-traumatic stress disorder involved in this situation?
I don't see that here.
Post-concussion syndrome?
I don't believe he has post-concussion syndrome.
What is post-concussion syndrome?
It is long-term report. Well, let me clear up. If we're talking about persistent post-concussion syndrome, are you talking about persistent post-concussion or just post-concussion?
I'm just stating Dr. Zackler's Axis 1 diagnosis. After he actually examined this patient, talked to him, talked to the wife, did the testing that he thought was appropriate and came to his conclusions.
Well, he's not allowed to do neuropsychological testing because he's not a neuropsychologist. So it's not even an option for him. All he can do is the psychological testing. But when he makes a diagnosis of cognitive disorder, it's based on a patient's self-report. And by his own testing here with MMPI, issues came up, red flags came up about how Mr. Rios was reporting symptoms. That's in Dr. Zackler's own report.
Did you do a global assessment of this man?
No,
In fact, you don't believe that's a valid test, do you?
I do not.
Do you have any appreciation of Mr. Rios' ability to conduct himself and deal with the activities of daily living before he got struck in the head?
I believe so.
And what was your assessment?
That he was working full-time. He was functioning apparently well on the job.
Have things changed?
Well, he's not working.
Anything else?
He has essentially lost vision in the right eye.
Anything else?
I believe that he does have a loss of taste and smell. That would be absolutely consistent with the injuries he sustained
How do you think that happened?
due to all the facial fractures.
You understand he has no useful vision in the right eye,
That's correct.
and he's not likely to get it.
That's correct.
Doctor, let me mark this. Where are we at here? We're on 11. This is the notice of taking your deposition. Have you seen that?
I don't believe so, actually.
what it is. It's my attempt to get you to bring down everything that I could possibly think of that might be germane to the case and prepare me to take your deposition. One of the things I want to focus on are references that you have made in your report. And with all due respect, Doctor, saying Boone 2002 doesn't mean anything to me. So do you have all of your reference materials that you referred to in your reports?
Not with me, no. But the way that you find these, it's actually very easy. You just type in Google Scholar, and you type in the author's name, the year, and then like the general content area. So if it's referring to a test, you type in the name of the test. So it's actually very easy to find these things.
Well, I don't want to go through that exercise, and that's why I did the notice. You felt it was prudent to put in here, and I'll just read one. Research conducted at Harvard UCLA shows that depression is associated with mild losses in discrete cognitive areas. And then you go ahead and visual memory, PIQ, processing speed, executive skills. Boone et al. 1995. Well, what would I type in Google?
You would type in Boone, 1995, and then depressive disorder.
Where's the report?
What report?
The one you referred to in this thing.
The publication?
Page 2, yeah. Boone, 1995. What's it called? Where's the article?
Well, it's in my Vita. Actually, if you go to my Vita, any article of mine that I published, you just, and you can type in the entire reference into Google Scholar and it will come up. So Boone 1995 is,
By the way, do you consider it good form to cite yourself in your reports?
I know that research the best. Okay, so this is item number 36 from my Vita is the reference that you're looking for.
What's the title?
It's called Cognitive Functioning in Older Depressed Outpatients, Relationship of Presence and Severity of Depression to Neuropsychological Scores.
Who's the lead author?
I am.
And Boone, 1999.
And which page of my report is that?
Same page, page 2.
Page 2? Oh,
Yeah.
we're talking about that report? Okay.
Yes.
So what was the date again on that?
I lost it.
I believe you said 1999.
1999? Okay, so that's in the middle. That was actually a book chapter, so that is on page 16 of my bibliography, and it is, the title of the chapter is Clinical Neuropsychological Assessment of Executive Functions, Impact of Age, Education, Gender, Intellectual Level, and Vascular Status on Executive Test Scores. And the book is The Frontal Lobes, published by Guilford Press.
Let's talk now a moment about the gliosis. You understand that was reported and was the etiology attributed to the gliosis was shearing force in the parenchyma of the brain.
I don't recall that wording. My recollection was that the neuroradiologist read it as possibly related to trauma.
And then you talk about research.
So that publication is Boone et al. 1992.
92?
Yeah, 92. Or maybe it's 93. It's 92 or 93. And the title of the article is Neuropsychological Correlates of White Matter Lesions in Normal Elderly, a Threshold Effect. And that was in Archives of Neurology, 1992, volume 49.
The areas of gliosis were restricted to the frontal lobes. Did you find that odd, ma'am? That's exactly where he suffered the blow. And it was not in other areas of the brain.
My recollection, it was the white matter. It was hyperintensities in the white matter, and the frontal lobes have the most white matter. So any condition that's going to cause white matter abnormalities is going to differentially impact the frontal lobes because they are the biggest area. But again, the research over and over shows, and I read medical records a lot, and I'll see lots of imaging reports, and they'll talk about white matter changes. And then they will say, most likely due to small vessel vascular disease. And this is the first report where the radiologist is saying due to trauma, and I'm thinking, every other report I've ever seen has raised first and foremost vascular issues. So then I said in my report, perhaps the radiologist reading this was not aware of Mr. Rios' 30-year history of high blood pressure, which is completely relevant when you're looking at white matter lesions.
Ma'am, white matter is throughout the brain.
It's in the white matter.
Correct. And the white matter is diffuse throughout the entire brain, is it not?
But mostly in the frontal lobes because those are the largest brain areas.
I got it, ma'am. But the white matter is present throughout both hemispheres of the brain, correct?
That's true.
And did you find it odd that the white matter gliosis was only in the frontal lobes?
No, no.
Is that consistent with trauma to the brain, frontal lobes, a finding of gliosis 4 months later?
Well, I can only really speak to my own experience, which I obtained through analyzing these data and writing this paper. But normally, when you see neuroimaging abnormalities related to a brain injury, it's things like encephalomalacia, which is where the outer cortex gets banged because it hits the inside of the cranium and gets bruised, and it's so badly bruised that it actually ends up dying and dissolving away. Or you will hear about axonal shearing, diffuse axonal shearing. But when you're talking about lesions just in the white matter, in somebody who has a 30-year history of high blood pressure plus diabetes, the first differential would be that it's small vessel disease related to his underlying medical conditions.
I understand your opinion, ma'am. Is it consistent with a blow to the head? The findings of gliosis, frontal lobes only, when the patient has suffered a blow to the front of his head?
In my opinion, it would not be. However, my expertise is limited to my own experience doing research, and I would defer to a neuroradiologist, but I would want that neuroradiologist to be aware of Mr. Rios' 30-year history of high blood pressure.
And when you say 30-year history of high blood pressure, did you see serial blood pressures for 30 years?
I did not.
Did you see any treatment records for his high blood pressure?
Yes, I did.
Did he respond?
What I saw was it said uncontrolled, and his blood pressure readings were still high. And there was a letter from him saying he had a significant high blood pressure episode, I think it was in 2007 or 9, and he was, he indicated he could hear his heart beating in his chest. So he has had poorly controlled high blood pressure.
Let me get this straight. You gleaned from the record that he wrote something where he had an incident where he was upset and he could feel his heart beating, that it was indication of long-standing hypertension?
No, the records indicate long-standing hypertension, that he was diagnosed with it at age 30, but in the records, he wrote a memo to a doctor saying, essentially, oh my God, my blood pressure's up, I can feel my chest, my heart beating in my chest.
The patient's subjective belief about his blood pressure in a note where he was upset, you're taking that as evidence of uncontrolled hypertension? Am I getting that right?
No, no. There are other references to uncontrolled high blood pressure, as well as readings in the records that are high. Plus, the patient then, in 2009, writes a letter saying, My blood pressure is going up. I can feel it in my chest.
On an incident.
What do you mean on an incident?
Ma'am, that's the letter I referred to earlier. It seemed to be pretty coherent and an intelligent person writing it, not some unsophisticated person.
I didn't say he was unsophisticated.
No, and that's the letter I'm referring to, where he said he got so upset about being treated poorly in a doctor's office, he got upset and he could feel his heart racing.
Oh, let me find it, because that's not my recollection.
Well, why don't you take a moment and see if you can find that. Because you're relying upon that as an evidence-based item to support your opinions.
No, I'm not. I mean,
Why'd you bring it up?
well, the records say he was diagnosed at age 30. The records show high blood pressure readings. The records refer to poorly controlled hypertension. And on top of that, in 2009, the patient himself said, my blood pressure is high. I could feel it in my chest. My recollection was that he was writing the memo because he was concerned about his blood pressure. So I found his letter, and he was referring to an episode he was unhappy with his care.
That's what I said.
Right.
I'm just wondering how you opined that he was able to know what his blood pressure was.
He says, my blood pressure shot sky high. Those are his words. So much I could hear my heartbeat.
And I think I already asked you this. You do not have any record of serial blood tests over time. You don't know how high it was. You don't know whether he was on medication that controlled it or not, etc.
I have records from 2007 showing incomplete control of his blood pressure and high blood pressure readings, references to severe hypertension.
How many readings, how many blood pressure readings do you think you saw?
I don't recall.
Well, can you give me an idea? You're talking 30 years, long time.
Well, the records only go back to 2007. So by definition, I don't have the readings prior to that.
Can you give me a sense how many blood pressure readings you saw in this man?
I would say 5.
Oh. Did you opine in your report that he has diabetic neuropathy in his hands?
I believe so.
You understand he has carpal tunnel syndrome, had it surgically
That's correct.
corrected, and he doesn't have it anymore?
That's correct.
What do you make of that? Is that diabetic neuropathy?
No. Has
He does
nothing-
not have diabetic neuropathy.
Well, somewhere in the records, I saw reference to that.
Well, doctor, are you diagnosing this man with diabetic neuropathy?
No.
Do you believe he has diabetic neuropathy?
I believe I saw it referred to in the records.
Did you see that it was in fact carpal tunnel syndrome, which was surgically treated, and he doesn't have tingling anymore in his hands?
No, I saw references to both carpal tunnel syndrome and peripheral neuropathy in the records.
And doctor, as true as it not that you pulled that out of the record and put it in your report to support your opinion that he had diabetes, which supports your opinion that that's a factor in the gliosis?
The records indicate that he was diagnosed with diabetes in 2007.
Who made the diagnosis?
I don't recall. It's in the medical records by treaters.
And was he treated for his diabetes?
I'd have to go back and see.
But you pulled that out of the record, and you came to the conclusion that he had diabetic neuropathy, and that supported your conclusion that he had gliosis from other etiologies other than a blow to the head.
And misstates your testimony.
No. I mean, I know that he has a 30-year history of high blood pressure, and I know that high blood pressure leads to white matter lesions on brain imaging, as does diabetes. In the records, I saw references to him being diagnosed with diabetes in 2007, references to peripheral neuropathy. I did not make that diagnosis.
The point I'm making with you, ma'am, so the jury understands, you pulled out of the record a reference to diabetes, and then you pulled out of the record a reference, I think somewhere, of a tingling in the hands. You concluded it was diabetic neuropathy.
Well, that'd be the most likely explanation. I think I also referred to carpal tunnel, but certainly if you've had carpal tunnel, peripheral neuropathy, and you're having tingling in your hands, those would be the considerations as to what's leading to it.
Doctor, you came to the conclusion, did you not, that he had diabetic neuropathy?
Objection X, then answered. Misstates her testimony.
In the records, I saw that he was diagnosed with diabetes and peripheral neuropathy. I didn't come to a conclusion. I found it in the records.
In your search of the record, did you see that he had EMG studies that were consistent with carpal tunnel syndrome, not neuropathy from diabetes?
I know that there were references to carpal tunnel syndrome. I'm not qualified to interpret EMG reports.
Why did you not put in your report that his tingling in the hands may be from a carpal tunnel syndrome? The only thing you put in there, ma'am, was diabetic neuropathy.
Well, in my experience and knowledge, certainly when you've got tingling and you know in the records that it talks about peripheral neuropathy, that would be the number one consideration.
I see.
Whether or not carpal tunnel syndrome leads to tingling, I have less experience with.
I take it you read Dr. Fisk's report. You disagree with everything he has to say, too?
Well, I don't recall everything that he had to say.
He says he suffered a mild traumatic brain injury and is currently symptomatic and needs to have treatment.
I think, as I said, certainly Mr. Rios may have had a mild traumatic brain injury 2 years ago. He would not still be symptomatic from that. He does not require treatment for that.
And you disagree with Dr. Fisk that the likely etiology for the brain scarring only in the frontal lobes is a result of being struck in the face with a high-speed object. Fisk is wrong, you're right.
I would actually defer to a neuroradiologist, but one who knows about Mr. Rios' 30-year history of hypertension.
You don't think Dr. Fisk was able to pick up a relevant history of hypertension and factor that into his conclusion?
He's not a neuroradiologist.
Do you feel that he is competent to diagnose the etiology of brain abnormalities, being a board-certified neurologist of over 40 years?
Certainly he's competent to be able to do that.
By the way, do you treat patients?
I do not.
Almost always. You see patients one time, you conduct tests.
All the time. I do assessments. I do not provide treatment.
Have you ever treated?
Yes, when I was in graduate school.
Okay, that's 10. Concerning traumatic brain injuries, do you agree with the theory of diffuse axonal injury as the etiology for the signs and symptoms that you see?
Well, in what context?
Either bruise them or kill them.
Certainly, many patients have diffuse axonal injury, absolutely. But I don't think you can make the case for that in a mild traumatic brain injury.
Isn't it true, ma'am, that in mild traumatic brain injury, data show that the neurons may be rendered dysfunctional but not necessarily destroyed?
I think that's an area of debate. It's out of my area of expertise.
It's in the book I just read. Take a look at page 16. You underlined it. By the way, is that Dr. McCrae?
Yes?
You deem that to be an authoritative work in the area?
Yes. So, I'm not seeing what you're talking about here.
Yeah, it's going to take a while. But I'll just ask you if you agree with the proposition or not, and I'll just represent to you. I found it in the book. It was underlined and tabbed as I was waiting for the reporter. Mild traumatic brain injury, the current theory is the neurons are rendered dysfunctional but not necessarily destroyed.
In the course of a mild traumatic brain injury?
Yes, ma'am.
That may be.
Do you have to lose consciousness to suffer a traumatic brain injury?
No.
Did Mr. Rios experience, well, did you come to a conclusion from history whether he was unconscious or not?
The hospital records seem to indicate not.
Is the Glasgow coma scale of any use in trying to assess traumatic brain injury?
Yes.
How about mild?
Yes.
You can have a perfectly normal Glasgow coma scale and still have suffered a traumatic brain injury.
A mild traumatic brain injury.
I think the cutoff is 13.
Correct.
People that suffer mild traumatic brain injury, about 85% are able to return to work.
Well, it depends on the severity of the brain injury.
It was mild traumatic. I might have misspoke. I thought I said mild traumatic brain injury. Data show about 85% are able to return to work.
100% are able to return to work, assuming that they don't have non-brain injuries that interfere with their ability to be employed, orthopedic injuries, etc.
I pulled that 85% number out of Dr. McCrae's book. It suggests 15% don't.
Well, you'd have to show me that, because the book also indicates that the meta-analyses show that there are no long-term consequences of a cognitive nature from a mild traumatic brain injury.
In meta-analyses, that's a compendium of work?
That would be where you take all the available literature, research literature in a given area, and collapse it for an ultimate conclusion. There have now been 6 of them, all showing no long-term consequences from a mild traumatic brain injury. And on page, as I indicated in my report, 117, I think in this book, Dr. McCrae concludes as well. No indication of permanent impairment on neuropsychological testing by 3 months post-injury.
Is it true that data show if the patient does in fact have a structural component to the brain damage, i.e. gliosis in the frontal lobe, they are at increased risk for slow or incomplete recovery?
Well, assuming that the abnormalities are actually due to the trauma.
Data show increased risk, low to incomplete recovery.
If there are brain imaging abnormalities, then it would move the person into the mild complicated category, and they can have a somewhat more problematic recovery.
You think Mr. Rios has had a problematic recovery?
From a brain injury?
Yes, ma'am.
No, I don't.
You understand Dr. Lechuga is a Spanish-speaking person?
Yes.
Has he published in that area of neuropsycho testing when you're dealing with people that Spanish is their primary language?
I don't think he has much of a publication record, actually.
Do you know if he's published in that area at all?
I don't know. I don't think recently, certainly.
You raise an issue of an ethical consideration with Dr. Lechuga, and I think you opine that he did not take into account Mr. Rios' his bilingualism.
I didn't
Did you
see-
mean to say that?
I didn't see any reference in his report anywhere to attempting to adjust for the patient's ESL status or bilingualism.
Well, ma'am, I'm just asking you so you have a chance to explain. Are you raising concern concerning Dr. Lechuga's ethics in his evaluation of Mr. Rios?
It's not my ethics, it's the APA ethics code. And if Dr. Lechuga does not consider, the ethics code specifically says that you have to consider linguistic and cultural factors in interpreting test scores. If Dr. Lechuga doesn't do that, then the ethics code, not written by me, would indicate that he's not in compliance.
And what makes you think that Dr. Lechuga, who speaks Spanish, would not consider that or make that a consideration in his overall evaluation of Mr. Rios?
Well, I would expect to see reference to it in his report, where he says, we've got a score here, even after we correct or adjust for bilingualism, his score is still depressed. Or after we adjust for bilingualism, the score is now normal. There's no references to anything like that anywhere in his report that I saw.
Ma'am, it's true, is it not, that people that are bilingual, and like Mr. Rios, where English is his primary language, that's what he uses all the time, it's spoken in the home, etc., that they in fact test better and do better in the tests that you perform because of their abilities to have two language skills.
Better than what?
Better than the norm, an English speaker only.
Absolutely not. I've done research on that myself, published in 2007 in the bibliography, showing that even when you learn English with another language, that you're still down on tests administered in English relative to people who only speak English. We documented that on our patients at Harvard UCLA.
Of that letter that Mr. Rios wrote that you referred to with his high blood pressure, what's your take on the sophistication level of the person that wrote that letter?
It was a well-constructed letter.
Think he can do it now?
Yes. I mean, currently, his vocabulary range is at the 75th percentile. So yes, I do think he could write a letter like that now.
Give me a second. What time is it?
7:47, 10:07.
10 more minutes.
Well, you got me, you know, so I have to say okay. Oh, do you advertise? Do you solicit business?
No.
You're not on the service that, on the net where you say that you are for hire
No.
for lawyers?
No.
Have you ever?
No.
Where's the big report? That's your...
Should be right there.
In your report, page 9, you included a long narrative. The following narrative is provided by the last publisher, and then you quote them. What was that about?
Well, this is taken from the report generated by the test publisher.
Why did you put it in there?
Well, it's showing what the test publisher concludes about the patient's responses to this inventory.
Yeah, if you could just summarize what's the intent of this information. What is the test provider telling those that are interpreting the test?
Well, they always discuss first the validity scales, and there was some evidence of inconsistency. This may result from reading or language comprehension problems, cognitive impairment, errors in recording responses, or carelessness. It doesn't invalidate the test protocol, but you have to proceed with caution. Then it also indicated that he was over-reporting physical symptoms rarely described by individuals with genuine medical conditions. It may occur in patients with substantial medical problems, but in the absence of that, it would indicate non-credible report of somatic symptoms. He also provided an unusual combination of responses signaling non-credible memory complaints. And so in the way that he described the memory problems aren't what we see with true memory impairment. And that the test publisher was saying that sometimes this occurs in individuals who are psychiatric. Alternatively, the person simply is just not reporting their memory complaints accurately. Then it talks about various physical complaints he's reporting. He's reporting diffuse cognitive difficulties. He reports lack of confidence, feeling useless, etc. He reports a significant history of acting out, antisocial behavior, poor impulse control, likely to have been involved with the criminal justice system, likely to have a history of juvenile delinquency, likely to have serious difficulties with individuals in positions of authority. He's cynical, distrusting of others, doesn't really like social events, etc. And the diagnostic considerations generated were somatoform disorder if physical origins for malaise and head pain complaints have been ruled out, antisocial personality disorder, substance abuse disorders, personality disorders involving mistrust of and hostility toward others, disorders associated with social avoidance such as avoidant personality disorder, no references to any depression or anxiety or PTSD.
And on page 10 of your report, additionally, this is the last paragraph, additionally the patient has shown evidence of white matter hyperintensities on brain MRI, while the radiology report attributed these findings to possible gliosis associated with residuals of traumatic brain injury. The findings would accurately be more consistent with long-term effects of high blood pressure. Doctor, that's a diagnosis. That's an etiology of white matter gliosis.
No, that's not a diagnosis. That's saying based on the research literature, what does the research say about the most likely causes of these abnormalities? It has nothing to do with a medical diagnosis.
And then on this, you cite yourself again, and this is Boone, 1993.
Actually, I think it's 1992.
Is that the same reference that you, that's just a
Yes.
typo?
Yes.
20 years ago?
Correct.
Done anything since 20 years ago?
In this area?
Yeah.
No.
All right, we could go longer, but I'm not. You only gave me 10 more minutes. We are likely to start trial on the 10th. Are you going to be in town?
July. Yes, I'll be in town.
Why don't we stipulate to relieve the reporter of her responsibilities under the code, send the transcript to counsel. You'll arrange to have Dr. Boone read, sign, and correct it under penalty of perjury. You'll give me notification, say a few days before we start trial if there's any changes. If I don't hear from you, I'll assume it was read and signed without correction. You'll be the custodian. You'll produce it at the trial. If you lose it, an unsigned certified copy can be used for any purpose.
Agreed.
We're going off the record at 6:55.